Okay, looks like we're recording. All right. So good morning. My name is Emma Roberts, and I am the Director of Capacity Building Training here at the Harm Reduction Coalition, and I am here with my colleagues. I'm going to invite Casey to introduce herself.
Good morning. My name is Casey Bitchek. I'm the Capacity Building Services Manager East here at Harm Reduction Coalition.
And my colleague Tanagra.
Good morning. My name is Tanagra Melgarejo. I am the Capacity Building Manager for the western part of the region for the Harm Reduction Coalition.
And we are here presenting our session on exploring and ensuring best practices for harm reduction programs and syringe service programs that was delivered to the Southern Regional Syringe Service Program Institute in Nashville, Tennessee on February 14th, 2019. So just to start us off, let's try that. Okay, to start us off, I'll introduce a little bit more about the Harm Reduction Coalition. We are a national organization that was set up in the early 1990s as part of a response to the AIDS epidemic at the time. And now our core programs include the following: policy and advocacy team that provides support to folks in relation to policy and advocacy at both the federal, state, and local levels to advance drug user health policies, including syringe service programming. We have a training and capacity building team that myself, Casey, and Tanagra are a part of that provide training and technical assistance, both in person and remotely, to people across the country who are again looking to develop harm reduction programming, including syringe service programs. We have a specific program dedicated to overdose prevention and response that particularly looks at access to naloxone, but also access to medically assisted treatment. At the moment, we're currently focused on expanding access to low threshold buprenorphine treatment. We also provide national and regional conferences, such as the Regional Institute in Nashville, but also our national conference that happens every 2 years. And the last one was in New Orleans last year. And so keep an eye out for the next one coming up in 2020. And then we have a range of resources and publications that we have available from our website that people can download or order on various topics. And we also just wanted to draw attention to our North Star statement that we adopted about 18 months ago alongside our mission statement, which reads: "The Harm Reduction Coalition creates spaces for dialogue and action that help heal the harms caused by racialized drug policies." The reason we adopted that is because as the opioid crisis evolved, we wanted to keep at the forefront of our work an acknowledgement that people from communities of color have been consistently disproportionately impacted by punitive drug policies and practices for a long time. And we didn't want to lose sight of that, even as we saw more white people and white communities being impacted by the opioid crisis, because we felt that was an important aspect to acknowledge. So the objectives of this session are to explore drug use and stigma in communities. We feel this is a really important thing to have at the foreground because this underpins the provision of services. I can provide syringe service programs, but if I'm not acknowledging drug-related stigma and how that impacts people, I can continue to exacerbate that in the way that I provide those services. So we keep that at the foreground of our discussions and what we're looking at when it comes to best practice. We want to then identify definitions and key harm reduction principles, and then discuss best practices and strategies to reach, serve, and engage people who use drugs through the development of harm reduction and syringe service programs. Just a little reminder of why we're here and why we need harm reduction. The United States is the largest consumer of narcotics in the world. There was a recent article in The Lancet that showed that even if the US reduced their consumption of opioids by 75%, this country would still be the largest consumer in the world. and it's estimated that over 27 million people have used an illicit substance in the past 30 days, according to recent research. And about 1 in 12 Americans need some form of substance use treatment, or have suggested that that's what they need or ask for that. And at the moment, only 11% of those people can actually access and receive that treatment. And the next slide just illustrates what the progression and evolution of the opioid crisis and the rising deaths from overdose. The first wave, which is in purple, is a rise in prescription opioids and the deaths related to those that started in the early 2000s. And then the second wave that started around 2010 was probably around the time when there was a reduction in the prescribing of prescription opioids, was when we saw a second rise of overdose deaths as people progressed to accessing the opioids and fulfilling those needs by accessing heroin and other street-based opioids. And then the third rise that we saw from around 2013 is related to the rise of synthetic opioids such as fentanyl and carfentanil that we've seen becoming introduced into the drug supply. And then this next slide just illustrates one of the points that I made earlier in terms of, where people are located in relation to access to substance use treatment and syringe service programs. So we can see from the first graphic that over 95 million people in the US are more than 10 miles away from a substance use treatment facility. And given the figures of how many people said that they needed substance use treatment, that's still a huge gap in access. And then if we think about, given that gap in access, which highlights the need for harm reduction programming and support as people prepare or wait for that access to come, or maybe where they live, there's it's not likely that they can get access for a long time, that their ability to access harm reduction services like syringe service programs is even less. So we see, over 260 million people that live more than 10 miles away from a syringe service program. So hence, the need to increase the availability of syringe service programming across the US. And then this graphic just helps to illustrate the rise in drugs that we saw in that third wave in relation to the presence of fentanyl or carfentanil. The graphic on the left shows you the differences in the amounts that you need to get a similar effect. So you can see that for fentanyl and carfentanil, there's much less needed to get this a similar effect to the amount of heroin in the first vial. So that's been part of the reason why people have not been able to, why we've seen a rise in overdose deaths, because people have not been aware of this. But we've been able, through harm reduction measures, to increase education around that, but it's an ongoing process. So at this point in the presentation, we'd invite the audience to participate by contributing who in their communities is most vulnerable to substance use, and also what are some of the current popular substances that people are seeing within their communities. And the reason for doing this is to support people to think about why it is they need to think about the range of people that they may need to provide for when they're operating harm reduction or syringe service programming. So, for example, it's not just people who inject drugs, it may also be people who smoke drugs. It may be trans folks who may need specific safer injection education around injecting silicone and hormones. And then in terms of the different types of drugs, again, we speak a lot about opioids because they're so high profile at the moment due to overdose deaths. But we need to be thinking about providing for other substances such as methamphetamine, crack, cocaine, and other drugs that people may be using, and the harm reduction education that they need in relation to that. And then building from that, just thinking about, in terms of vulnerability, people living with HIV and the additional vulnerabilities that may bring for them, especially if they're also using drugs, which can lead to elevated risks of harm, health complications, and overdose. So making sure that our programs are providing testing and access to care and treatment for those who are living with HIV. We know that 9% of new HIV cases and 65% of new hepatitis C cases that are diagnosed across the country are related to people who use drugs, and in particular people who are injecting drugs. And in some communities, those percentages are much higher. For example, in Indiana, where we saw the HIV outbreak in Austin, Scott County, over 80% of the people that were tested positive for HIV also had hepatitis C. So thinking about things like co-infection and how we support people around that is in our programming is also super important. The other thing to think about is that women who use drugs who are living with HIV also have elevated risks as a result of structural, social, cultural prejudices and punitive drug policies, and often find it harder to access the services that they need. So making sure that we are considering that when we're designing and developing our services is also super important. Yeah, move on to the next slide. And then the other thing that we want to highlight is the access to harm reduction for communities of colour, because we know that communities of colour, as I said earlier, have been disproportionately impacted by historically punitive drug policies. And this can impact how safe people of colour feel in accessing support services, including harm reduction and syringe exchange. So, for example, when we're talking to people about accessing naloxone and responding to an overdose, in some communities, calling 911 may not feel safe at all, especially in communities of colour where past interactions and historical interactions with police have been very unsafe for those for individuals and people in those communities. Another example from our work is supporting the development of the new syringe exchange in Miami, which is located in a historic African American community in downtown Miami. And in the beginning, they were predominantly seeing white folks attending the program. So we, as part of our technical assistance, we work with the program to think about the kind of outreach and who was doing the outreach in that community in order to find out what the needs of people of colour were in that community and why they might not feel safe to come by the exchange. For example, maybe they feel like they would be socially profiled in a different way, maybe stopped by the police more than some of the white participants that were attending the program. So thinking these things through. And we also just wanted to highlight a recent magazine article in Filter magazine that challenged us as harm reductionists to really be more mindful of building bridges with abstinence-based providers. Abstinence is a part of our spectrum of interventions as harm reductionists. And what the article spoke about was that in communities of colour, abstinence-based treatment has been, as people feel, is it's known to be a safer response for communities that have been disproportionately impacted by the laws and practices in relation to drug use. So we need to think about framing harm reduction for treatment providers who are working from an abstinence-based modality in a way that engages them and doesn't push them away from harm reduction. One of the ways I talk about it is adding extra tools to their toolkit to be able to support people towards abstinence, for those people who are choosing to work towards that as part of their recovery. So I'm going to hand over to Tanagra now, who's going to talk to you a little bit more about stigma.
Thank you, Emma. I think, just reflecting on what you were speaking about the different intersections of people's identities when we are thinking of providing services and how those intersections sometimes can magnify the person's experience around stigma when we're thinking about offering services to folks that are African American. It's really important to think about the relationship, not only to their community, but to different structures within that community, such as the police force and what's experienced with the police force, and then what does that mean in terms of those folks feeling safer accessing services or carrying naloxone or potentially calling 911 in case of an emergency, right? And so when we're thinking about programming, it's really important to think about, what is it that we are doing to support folks, and what are the things that we're putting in place that may perpetuate stigma or the experience of stigma that people already bring with them in terms of the ways that they engage and interact with different systems and structures that are in place already. So one of the things that we've noticed is that sometimes, and I think that this is something we would ask folks that were participating in this workshop to think about if they've heard, some of these things when they've had interactions with clients or program participants. If these are things that resonate with them when they've had these conversations. I know for myself, I've heard these things, and I know for Emma and Casey as well, and that's why they're here. And these are things that show us that that stigma is a huge barrier when folks are trying to access services or treatment, because that judgment is there, and because that discriminatory treatment is very much real and present. So when we're thinking of setting up services, it's important to think about how is it that we can shift that? How is it that we can create services and provide services from a framework of autonomy, of liberation, of respect and dignity, which are the antithesis, and I think actually are the things that can begin to heal the experience of stigma for people. If I can have the next slide, please, I would appreciate it. And so the way that I think of stigma, and I'm someone who's really visual in terms of my learning, and this framework for thinking about stigma helps me understand it and put into words an experience that is very much something that we feel internally, and that it's sometimes hard to describe because it's not something that it's tangible, although it's very real. So when we think of stigma, stigma starts with the development of stereotypes and ideas that we hold about certain groups of people, because those groups of people are either different from us because we don't understand them, or because we have been taught by systems and by structures to be afraid of them, to fear them, to keep them away. So when we think of people that use drugs, for example, we can start thinking or creating ideas in our heads that then become stereotypes about them being incapable, fragile, dangerous, or that they cannot recover or don't want to recover, or the path that they're choosing is not the path that we want. So then therefore they're weird and strange and we don't want them near us. And then those ideas move into the area of beliefs. They become cemented and they become prejudice. And then we start saying and thinking and feeling that they are scary, that folks are shameful, that they're less than us, right? And then from those ideas that then become beliefs, we go and move into actions, things that are tangible and palpable that people experience, and that's discrimination. And our participants and folks can experience discrimination in two different ways. They can experience social discrimination, which is very much when we hear folks saying, oh, we don't want that program in our community, or we don't want those folks coming in here to receive services, or I don't want their kids to be in the same school as my kids, or I don't want, them to live near me. And then there's a structural piece, right? Which is when we're not hiring people with a history of substance use, or we don't want to refer them to programs because we're afraid that they're going to make us look bad because they're not compliant, and we kick them out of programs, or we don't offer them the medication that they need because we think that they're coming in and they're drug seeking and they're lying to us. And so those structural pieces and that social piece compounded really harms and hurts people, because if you are someone who experiences this on a daily basis in every single system and structure that you come across with, it's going to be really hard for folks to trust that someone is going to treat them differently. And this is why harm reduction programs are successful, because they show people, they build trust, and they can show people that they can actually do and want to do things differently for folks, and they want to treat people with dignity and respect. And in order for harm reduction programs to do that, we have, as people who work in them, have to be really aware of our own prejudices, our own stereotypes, and the way that we can discriminate folks advertently or inadvertently when they're coming in for services. So we have to be really mindful of the ways that we can stigmatize people. And as programs, we need to have those conversations collectively. Everybody who is part of this program needs to have this conversation, so we are all aware of the things that we are and we're not doing for folks. Next slide, please. And so this would be another part of the training where we would ask folks to share with us whether they agree or disagree with some of these statements. I know for myself that when I read these, there's things that I have, experienced and that I have thought. I thought in my head, sometimes, the idea that I don't understand why someone doesn't stop using drugs, because the way that I'm thinking about it is I am thinking about it, I would stop. I, Tanagra, surely would not do that. But, once I reflect on that, I realize that this is not about me and my process, that this is about someone else's process and someone else's life experience. And that because it's not about me, what I need to do is sit down and try to understand and listen and empathize and create a space of dialogue that it's rooted in transparency so that this person can feel safe sharing with me what their experience is with substance use and what are the things that they're getting from their substance use that is helping them survive and what are the things that are harming them and what do they want to do about it, if anything, right? So that's the moment when we create those spaces for dialogue and conversation and reflection with folks that are rooted in empathy and not in stigma. So I think that this exercise is really helpful to have a conversation as staff around some of the things that we think and feel, because we're humans and and we're socialized within the same structures and systems as our participants, and we hold our beliefs and our values that are rooted in our experience, and we bring those, and that's fine just as long as we don't impose those on someone else. So it's about creating a space for us as providers for reflection and to be really aware when we are imposing those beliefs on people and how those beliefs that we're imposing can harm and perpetuate stigma and deny people the opportunity to be engaged in services that may be life-saving for them. Next slide, please. And so the way that we can combat stigma is by engaging in what we call a virtuous cycle, which is creating a culture of safety within our organizations and the programs that we run and the spaces that we create for the people that we serve. And so we want to create spaces that are positive, for people that use drugs and the communities that surround them. We want to make sure that we're developing interpersonal linkages with not only with program participants themselves and with them program participants and other parts of our program, but also we want to develop linkages with other organizations and programs within the community that are interfacing and interacting with our program participants. And we want to make sure that when we're developing those linkages, that folks we're referring to services are going to be treated with the same dignity and respect that they hope to find within our programs. We want also to create a climate of organizational trust, and that means creating a space for staff to be able to have these conversations about how, is it that we engage in dismantling stigma? How is it that we can concretely do that? How is it that we can be safe in sharing, our experiences, our thoughts, our ideas, but also the areas in which where staff are struggling and how we can support each other to develop a different framework. We also have to work in rebuilding systematic trust. And I think that's the piece that is the hardest when we're working with folks that have had really terrible experiences interfacing with systems and structures that are meant to hurt them, that are set up in a way that it's not to work towards the liberation of people, but actually to continue to keep people oppressed. And so if we are working with folks that are already distrustful or mistrustful of the systems, we have to, have those conversations with participants. We have to talk to them and create spaces for participants to feel safe sharing with us what they need from us in order to feel safe within our spaces. And that leads us to creating spaces of cultural safety. How is it that, I remember, I think it was Casey that said, we can be thinking that we're providing harm reduction services, but if we're providing the harm reduction services, we're providing the tools and the equipment with a huge spoonful of stigma, then that's not harm reduction. And so I think when we think of cultural safety, is it our spaces reflecting the participants and the population that we're serving in a way that is uplifting them as human beings? Are we welcoming them into our space and making them feel that they are safe? Are we using language that reflects their experience? Are we engaging them as equal partners in this process of transformation and change? Are we listening to them? Are we able to create spaces for participants to share with us if things that we're doing are working for them or not? Are we engaging them as equal partners in this process? And that's the pace of cultural safety that is so important for us to be mindful. And that's something that if we can create, really helps us lower the threshold that people have to experience in order to receive services and to feel safe coming into our programs. Next slide, please. And so some of the things that we can do to reflect and evaluate whether or not, we are creating a culture of safety instead of a culture of stigma, and what are some of the strategies that we can put in place to overcome some of the things that people experience outside of our space are, as I said, having visuals that reflect them, that people see themselves reflected, that they see people that look like them up in pictures in the wall, right, or in images. Make sure that space considerations are taken into account when we're creating programs. Sometimes the reality is, as I have said before, programs, we can't choose where our program is located. If it's particularly a fixed site, because it may mean that it was there before we got there. So I had the experience once of a participant having to go through a program where they had to go through a metal detector. And one of the things that we shared with participants was that, maybe we could accompany them if it made them feel safer. It would mean that maybe the person who I was referring them to in that program could come down the stairs and meet them downstairs and welcome them into the space to help ease some of the tension and the nervousness that they felt around, the experience of going through a metal detector, because that's not pleasant for folks. So that's something in terms of space considerations. Is my program next to a police station? What does that mean? How is it that I can make folks feel safer and less threatened coming into my space? Making sure that we create alliances within our community. Our community, it's important to do this because they can be our biggest supporters, and they can support our program participants. And we should involve small businesses, we should involve pharmacies, we should involve community centers, schools, we should involve the libraries, everybody in the community. And part of that is creating very honest conversations and dialogue, and sometimes challenging some of the notions that people have around folks that use drugs. So that means that we have to, in some ways, do some advocacy work to create a safe space in the community for ourselves and our programs and our participants. It's important for us to reflect our policies and practices and see if those are perpetuating stigma for folks, if they're creating huge barriers or really high thresholds for folks to access services, as well as review our forms to make sure that we are using language that is appropriate, that feels comfortable for program participants, that reflects the diversity of the people that are coming to receive our services. And finally, something that I think is key and crucial that we should all be thinking of doing and acting on is hiring and training people that use drugs to work in our programs, people that have that lived experience. Sometimes we ask people to come and support our programs. We ask them to help us design programs. We hire them as consultants, but we don't pay them for their expertise, and that is exploitation. So we really need to think about, if we're asking someone with lived experience to help us develop better programming, we should be paying them and we should be hiring them. I think, Emma and Casey, this may be the piece where I hand it over to you, correct?
Yes, that sounds right. So yes, we just want to reinforce in our programs that from the front door to the back door, all folks who use drugs, all folks engaged in sex work are welcome. And so part of how we do that is by thinking through how we define harm reduction. You may have heard lots of different definitions of harm reduction. I think everyone who practices harm reduction has a different personal definition. Here at Harm Reduction Coalition, we like to think of harm reduction two ways. We like to think of harm reduction with a small h and a small r as those interventions and practices, as syringe distribution, as naloxone distribution, as medically assisted treatment. However, we also like to think of harm reduction as a movement that we give a big H and a big R to. And that movement is based in political and liberatory frameworks that shift power and resources to the people who are most vulnerable to structural violence. So as Emma's already said and Tanagra has already said, it's really important to remember that harm reduction interventions are not always capturing the full spirit of harm reduction. You can hand someone a syringe, but if you are handing them a syringe and saying, I'm only giving you this until you get off drugs, you're not practicing that liberatory framework that acknowledges that people have been vulnerable to structural violence and we need to shift power back to those people and their communities. Going along with that, something we'll often hear is that harm reduction is in opposition to abstinence. It really isn't. Emma and again Tanagra have already mentioned, because it's really important to us, that abstinence is not what harm reduction is hinged upon, but it is a part of the spectrum for folks. So if folks come into a syringe service program and say that they are interested in becoming abstinent from any substance, we will support them to get there. But just as important to us is to support people who don't feel ready to stop using substances, or who think that they might not ever feel ready to stop using substances, so that we can keep those folks as safe, healthy, and empowered as possible, whether that means they are just using whether that means they're using a sterile syringe every time, or managing their use so that they are using less than they were before, or only using at certain times of the day, or only using on weekends. Whatever recovery looks like for folks, that's what we want to celebrate. And so in doing this, and in thinking about how drugs harm people and impact people, we like to use this model developed by Norman Zinberg in the 1970s, which is a drug set and setting model. So Dr. Zinberg studied a number of people who used different substances throughout the 60s and 70s and published his findings in the 80s. And what he found is that it's not just the drug that causes harm, and it's not just the drug that creates the experience that someone has when they are using that drug. It's the drug certainly contributes, but also the setting, so the physical location where someone is using, but also their emotional background, their economic background, their cultural background, and their internal set, so how they're feeling in that moment, their demographics, their characteristics. Tanagra said earlier that the intersections of identity magnify experiences of stigma. They also can magnify experiences of harm related to substance use. So for example, you might feel different having a drink at home at the end of a long work week because you're in a set to chill out and in a setting of your own home. So that drink might relax you, whereas were you to go out after a long work week and have a drink at a bar or club, you might feel a little more energized, a little more excited by that drink. Same drug, but different set and setting, so you feel differently. Another great example that illustrates the ways that all three of these things can contribute to levels of harm is someone who is injecting heroin in their own home with access to a clean surface to mix their drugs on and proper lighting, and a friend or family nearby who they know could reverse an overdose, has a much different set of possible harms than someone who is injecting alone in a McDonald's bathroom, unsure of what would happen if they overdosed. The second person has a lot more risk, not just of overdose, but because the first person certainly could overdose on that drug as well, that they have their overdose reversed. But that second person also has a risk of criminal justice involvement that's compounded if they're a person of color or a trans or non-binary person. Possibly if they're a parent, a risk of involvement with child protective services, if depending on where they live, a risk of jeopardizing their housing situation. So the levels of harm are very different for folks depending on their drug set and setting. It's not all just dependent on the drugs. So with each harm reduction program, we try to encourage folks to think through and apply the principles of harm reduction. These are something that the original staff of Harm Reduction Coalition came up with 25 years ago. I think that they hold up very well. I highly recommend, because there are about 12 of them, and we've just highlighted the 6 that we feel are most important, I highly recommend you check out some of the resources that Emma mentioned earlier on our website if you have a minute and read through them all. But the 6 that we've really pulled out as being essential to running a harm reduction program that operates in that liberatory framework that we're talking about are recognizing health and dignity. This has been repeated a lot throughout this presentation, but we want folks to be well, and we want folks to be seen as a whole person, not just as a person who uses drugs, not just as a person who engages in sex work. So that would mean allowing folks access to vital treatment, whether it's hepatitis C or HIV treatment, whether or not they're actively using drugs. We also want to be participant-centered, so meeting people where they are, not where we as service providers hope they will be. So if someone comes in and says, hey, I would like to stop using, but I'm not there yet. I would like to go into detox, but not today. We're not trying to encourage them to change their mind about that. We're offering them the services that apply to them in this situation, in this moment. So that's great. I can give you a few numbers for detoxes for when you feel ready to go. In the meantime, do you need any sterile equipment? We also want to encourage participant involvement. So Tanagra talked a little earlier about hiring people who use drugs as staff. We certainly want to do that. We want to involve participants in participant advisory boards or consumer advisory boards. And we also not only want to involve participants in the design and delivery of our individual services, but as we are working towards policy changes that affect people who use drugs, that affect people who engage in sex work, we want to engage people affected by these issues. We want to engage our participants and ask them what they think and what they feel is best for them, and again, pay them for that time and expertise. Participant autonomy means that we encourage folks to make their own decisions and respect the decisions that they make. Something that I was asked a lot when I was a Syringe service provider is whether I ever had a participant who had never injected before and wanted to start, and what I did in that situation, because for some folks it can feel like a real gray area. And what I did in those situations, because it did happen when I was working in a Syringe service program fairly often, someone wanted to transition from smoking or snorting or swallowing drugs to injecting, is I would sit down and have a conversation with them and talk to them about all of the factors related to injecting. I would give them all the information I possibly could give them and let them make that choice for themselves. We also want to consider sociocultural factors. So again, going back to set and setting and going back to stigmas that folks experience, we want to recognize that due to our society being a white supremacist capitalist society, people have different experiences of harm and experiences of trauma based on experiences of racism, homophobia, sexism, and all sorts of other oppression, and just personal experiences. And so we want to acknowledge that not everyone's trauma is the same and not everyone is impacted by our society in the same way. And that creates different levels of risk for harm, for both dealing with drug-related harm and also exposure to drug-related harm. And finally, we want to be pragmatic and realistic. We don't want to minimize the risks of drugs. In the example I gave earlier about talking with someone who was considering starting to inject, when I said I gave them all the information, I mean I gave them all the information. I would tell them injecting potentially would put you at more risk for contraction or transmission of hepatitis C or HIV than snorting or smoking. Injecting puts you at risk of having abscesses and blood infections that snorting and smoking may not, or may have a lower risk for. So we want to be practical and realistic. We don't want to minimize risks. We acknowledge that there are harms and risks involved with the drugs themselves and involved with set and setting factors. And we want to be very realistic in talking with people about those. At this point, we would ask the group to discuss the principles of harm reduction and talk about which principle or principles really resonated with them and which principles or principle felt challenging to them, and they may be the same principles. And the reason that we do this is just to acknowledge that we all struggle in this work, and it can be really challenging to adhere to these principles when we've been taught not to by so many other systems and structures. We also think that discussing these in small groups gives a really great opportunity to brainstorm ways to be more participant-centered, ways to encourage and support more participant autonomy, ways that other folks are thinking about that you may not have thought about to acknowledge folks' health and dignity and support folks' health and dignity, etc. And now I'm going to hand it off to Emma to talk about recovery.
Thank you, Sandra. So yeah, I'm just going to come in at this point to talk about the kind of evolution of how we talk about harm reduction and also redefining what we mean by recovery. And what's been really helpful for us to consider and discuss with people that we're working with around this topic is the SAMHSA's working definition of recovery that they recently introduced, and they define this recovery as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And when we saw this really resonated with us because it seemed, to really connect with the spirit and the philosophy of harm reduction in the way that we approach our work with people. It did not explicitly say anything about abstinence in there, so again, that speaks to how harm reduction is not, it includes abstinence, but it's not hinged on it. And then SAMHSA also included as part of dimensions of recovery these 4 areas: health, home, purpose, and community. So again, this connected to us in terms of, seeing someone as a whole person, looking at everything that's going on for them, considering, the structural and social inequalities that they may be experiencing across their lives, thinking about, drug setting when we're thinking about supporting people to make changes. So, this has been a really helpful way for us to connect, especially with treatment providers that have traditionally come from more abstinence-based modality, to help us engage them in conversations around harm reduction as well. And then just to summarize, before we move on specifically into looking at syringe service programming, the range of harm reduction services that are out there, that we include. So, from syringe access and disposal to different types of safer drug use, access to naloxone and medication-assisted treatment. When, there's a lot of discussion about supervised consumption spaces. They may also be called safe injection facilities, or we're also seeing the term overdose prevention facilities as well, where people have a safe space to come and use that is not the McDonald's bathroom, right? If they don't have a safe space at home or somewhere where they've got people around them to look after them, that there's a space they can come and use where there are people there available to respond if there's an overdose, to provide them the sterile materials, to talk about safer use, and also to provide referrals. The safe consumption spaces that are already out there in different countries are always connected to a range of services, including treatment. Provision of specific drop-in centres for folks, housing first access, pharmacy access to materials and support, and then supportive referrals. So there's a whole range of things we're doing when we're talking about harm reduction services. And then, so moving on to syringe service programs, and the picture here is a nod to our history. It's a picture of Dave Purchase, who started one of the first syringe service programs in the US in Tacoma, Washington, and he simply set up a table on the side of the street in the late 80s and early 90s and started to provide people with sterile equipment and a place to, you can see there's a sharps container there to dispose of their used syringes as well. if you want to move to the next slide, thank you. And this graph just shows the rise of syringe service programs in the United States since the early 90s. And if you look at the very end, close to 2015, that grey area towards the right, that's the increases we've been seeing since the HIV outbreak in Scott, Indiana, which mobilized a lot of people in the states, in Indiana and the states surrounding it, to begin to think about and develop syringe service programming. And that's had a knock-on effect across the country, where we've seen a dramatic increase in numbers. And what this graph doesn't show as well is the number of underground and grassroots programs that are popping up across the country, where people are responding to what they see as a health emergency in their communities. And they, even before the legislative approval is fully in place, they're beginning to respond with the support of their communities very often to keep people alive, basically, because of the impact of the high numbers of deaths. And then in the next slide, you can see though, so at the moment, our syringe service program in the US, which is the yellow column at the end, is still very low per person in the US. So in Europe, you'll see that it's there's many more syringe service programs available per person in those countries, but in the US, it still remains very, very low coverage and not as much access to syringe service program that people need. And this graphic just relates to the 220 counties that the CDC recently identified as being vulnerable to HIV outbreaks across the US. And what you'll see out of those 220, there's around 198 vulnerable counties that still don't have an above ground SSP. So again, that's why we're here. That's why we are talking about this. That's why we're trying to support people to expand that coverage, especially in those in the states that have those vulnerable counties located in them. And then just just wanted to draw your attention to this really great piece of research, which is a few years old now, but we like to include these statistics and research for you because as people are going out into their communities to try and get community buy-in, there's this balance between telling the stories and then also providing some data and research to back things up, to show how evidence-based these are. But basically, there was a research carried out a few years ago that showed that higher syringe coverage, which is basically the access to the number of syringes that people have, it's associated with the lower odds of HIV transmission, and at the same time, the more syringes people have access to in their community, it's been shown that it does not increase the unsafe disposal of syringes. And that's often something we hear in communities, like when a syringe exchange comes along, well, we're going to see more discarded syringes. And what the evidence has shown is that we don't see increases in many communities. We see a decrease because people now have a place to dispose of those syringes. And this also speaks to distribution models, which Casey and Tanag will talk about in a moment, where we want to really be promoting needs-based distributions over 1-for-1 or 1-for-10 based distribution models, because the more syringes that people have access to, even what this research shows beyond 100%, so that they have a few more than they need, that's really going to help reduce their risks of HIV transmission and hepatitis C transmission. And this final data slide just shows the cost of treating people versus the cost of syringe exchange for HIV and hepatitis C. And this is based on the Scott County outbreak, where we can see that towards the end of the outbreak, we saw 200 or a little over 200 people that were diagnosed with HIV, and over 80% of them were also diagnosed with 170. And what the statistics tell us that the cost of treating that is 529 times more than the cost of having a syringe service programming available. So this speaks to the cost effectiveness of providing these services compared to having to treat people. So I'm going to hand back to Casey and Tanaka for the next bit.
All right. Tanaka and I are going to talk a little bit more about syringe service programs. specifically in different models of syringe service programs. But before we do so, we just want to remind y'all that syringe service programs are backed by science. They are a science-based intervention proven to decrease transmission of HIV and hepatitis C among people who inject drugs, people who use drugs. They don't increase drug use. There have been many studies that demonstrate this. They help to prevent HIV and hepatitis C. They increase the likelihood for participants to seek treatment, and a lot of that is due to the things that Sandra was speaking about earlier when she spoke about stigma and the fact that folks are coming to a place where they feel that sense of cultural safety and they feel like they are being seen as a whole person, and so they are able to seek out treatment once they make those connections and they don't have that same distrust that they may have experienced in other social service settings. And as Emma's already addressed, they don't increase unsafe syringe disposal. Same study that Emma mentioned is referenced right here. And just to note that federal funding can now be used to support syringe service programs for everything except for the purchase of syringes and cookers. That means that other supplies, staffing, overhead like rent and utilities can all be paid using federal funding. And now I'll let Sandra speak a little bit about different syringe service program models.
Thank you, Casey. And I would love to co-facilitate this piece with you. So jump in at any time to share your expertise and thoughts on this. So there are several different syringe service program models. And one of the things that we usually let people know is, it's important to think about your community, your reality, the experience of the place that you're at, and then think about which of these modalities or which mixture of these modalities would make most sense for you. One way that you can find that out is by talking to people who could potentially be using your services. So talk to people who use drugs or engage in sex work and ask them what would work best for them. And that would just give you a really good head start in terms of determining then what kind of modality or program model you should put in place. But there's four main ones that usually people adhere to. There's the storefront model, and just a caveat that all these programs have their benefits and also can present some challenges, right? So when we think of a storefront, that is a fixed site, that is a space, that it's in a fixed location, that folks know where it's at, that it doesn't move or go anywhere, where folks can, during particular set hours of the day, go and access services. So the advantages is like a fixed site, so people know and have a certainty of where this program is located. So they, know that on Monday, Tuesdays, Wednesday, Thursdays, and Fridays from 9 to 1, they can go in there and access harm reduction services. They can access case management, et cetera, et cetera, et cetera. Some of the challenges with storefronts is, as I was saying before, that sometimes they are not located in spaces that may feel safe for program participants. Sometimes they are located in spaces that are near police stations, or they are within structures or other organizations that are offering services that folks may not feel necessarily so comfortable going into. For example, I remember a program that was within sharing space with a program that provided HIV prevention services and treatment. And so a lot of the folks that were coming in there felt that if they went in there, people in the community would think that they were going in to receive HIV treatment and not receive harm reduction services. And so that was a challenge in terms of that, because of the stigma associated with folks living with HIV. Some folks could also say, hey, I don't feel comfortable going into that building because I have to go through 5 different stations to get to the syringe service program. I have to go through 5 different persons to be able to access, and then they will know my business, right? Particularly in small communities, this can be a challenge in terms of storefront. Casey, is there anything that you want to add in relationship to the storefront model?
Yeah, I would just add that while it's great to have, it can be a pro to have a storefront and a fixed site, it can also be a challenge as your community starts changing, particularly for programs in larger cities that are gentrifying right now. It can be really difficult for participants to continue to come down to your storefront if the neighborhood that it's in is no longer welcoming to them and or no longer an area that they would choose to hang out in were your storefront not there. For programs starting out, it also can mean high overhead in terms of rent and utilities.
And just to add, that they can also be similar to what you were saying about gentrification. They can be a target.
Yeah.
But you know, you're there. People know. You know, community members know where you are, and if they're not happy, then there's actually a physical location that people can target their discontent or anger towards.
That's correct. And so, you know, one way to combat that is to engage in a lot of the community building that we were talking before, and really creating a safe space for having conversations around harm reduction and demystifying a lot of what harm reduction is, so that people can then become supporters and, you know, and make sure that they're protecting the program as well. But that also can mean more work, extra work for the participants and extra work for the program, for program staff, right? And it can be draining for people. So that's something to keep in mind, right? Go ahead.
Absolutely, Samantha. Yeah, I was just what you made me think about is the way that we've been talking a lot most recently about engaging faith leadership. And historically, faith leaders in churches have been some of the places that have provided safe, fixed locations for people to operate out of, you know, and have been able to kind of help steer the rest of the community in a more supportive way towards it, when people have found it hard to find other places to locate themselves.
Absolutely. So that, yeah, absolutely. That would be another option to consider for folks where they have those relationships in their community. And so if we think of other models, we can think of the street-based model, which is mobile outreach, or you can do it in a van, you can do it in a backpack. I know folks that do it on bikes, and they do it also on skates. So that really means, you know, you go where people are at. You offer your services because you are mobile, so you can reach folks that are sometimes hard to reach, folks that may not necessarily feel comfortable coming to a storefront. So that's an advantage. An advantage is also that it gives you flexibility to be in different parts at different times. So that means that you can cover a broader area of services as well, and reach more people, and make your services accessible to more folks. Some of the challenges that we've heard, similar to storefront, is that sometimes if folks have a van, they need to be able to find a spot to park it, and sometimes the community may not necessarily be welcoming of that. Sometimes one of the challenges is, particularly in, as Casey was mentioning, very fast gentrifying cities, is that folks that are in encampments or that are facing housing insecurity or that are houseless tend to be moved by the city government very frequently. They are being pushed away from the places that they normally are. So sometimes, you know, it's hard to keep track of where folks are at, because that can change very quickly and suddenly. And so part of avoiding some of those pitfalls is really maintaining close communication and relationships with people that access our program, so that they can give us word when that happens. I would say also that, similar to storefront, when we go into some of the spaces, to be mindful of, you know, making sure that we're not targeting our program participants, because sometimes what we've seen is that, you know, sometimes there's, as soon as they know that certain service programs are coming into the spaces where folks are living and keeping themselves protected, then police force suddenly shows up, you know, things starts happening that make the community that is there feel more unsafe. Is there anything else that both you and Emma and Casey would add to this particular model that you would want folks to think about?
Yeah, I'll just add that again, mobile outreach can be a really great way to reach folks who wouldn't necessarily come into a storefront, but it also can be challenging in the initial startup phase when you're trying to reach folks who may not have access to a phone or to the internet, and it may present a challenge in terms of communicating where you are and where meeting places are, and that's something to think through.
Yeah, I think yeah, I think for me, having run mobile programs in the past, that ability to move is a real benefit, especially when things change or if things become unsafe. We had one site where we really became targeted by local community members, and we were able to move in a way you can't really. It's difficult to move a building. But I think some of the other challenges are things like logistics, like weather, keeping your vehicle maintained and on the road, dealing with breakdowns and things. So those have been some of the challenges. Not that you can't overcome them, but yeah, there's things to really think about when you're planning your program, when you're budgeting your program, you're budgeting for maintenance. So there's some things to really consider and keep in mind.
Yeah, and in the same vein as maintenance of a vehicle, if you are on foot, bikes, or any other sort of wheeled non-engined mode of transportation, there's a limit to what you can carry and what you can distribute.
Absolutely. Yeah. And I think part of also thinking about street-based outreach, particularly for folks that are starting programs, is to maybe, and this goes back to those community linkages and community connections, right? And building those relationships, is to think about who in our community is offering services that is potentially connecting to folks that may want to receive harm reduction services, and develop those relationships. So maybe they can help us become introduced to folks in the community in a way that may feel safer for the folks, right? Because they already have a relationship with those participants, and they can help us then build one. And also weather can be a challenge, particularly in places where there's extreme weather. When we're thinking of street-based mobile outreach, whether it's driving, but also when we're on foot or on a bike or in skates, if it's snowing, if it's sleeting, if it's really heavy rain, I would say some places where it's really, really hot also, in terms of making sure that our staff, can keep themselves safe as well as support participants is also something to keep in mind.
And something you just made me think about, Tanagra, is when you're saying about building relationships with the community, what we did is we had a range of things that, anybody in the community could come and get, condoms, safer sex supplies. We provided syringes for diabetics, and even if they were getting them prescribed, they could come and bring their used syringes to the vehicle. So, and anybody could get a HIV test at the vehicle. So, from the community. So provision of wider services to the broader community is a really good way to engage people and gain their support.
Absolutely. And I would, I think that also when we're thinking of these modalities and the way that we can, you can connect, or you can think of maybe having a mixture of both of them, right? Like have a storefront, but you also have a street-based outreach, or you're a health department, but you partner with a CBO, and you can have several sites or satellite sites within the CBOs, because those CBOs can connect to program participants maybe in a way that as someone from a health department you can't, or because you're challenged because of the structural constraints, so those are things to keep in mind as we're thinking of these models. And I think my favorite model is the secondary or peer delivered, because I really think this honors the principles that of harm reduction that Casey spoke to us about, particularly being participant centered and participant autonomy, right? And when we think of secondary or peer delivered exchange, is basically when we have folks that are part of the community, that are folks with lived experience that are using drugs or have used drugs, that are able to share with folks the syringe service programming with them. They can give them the supplies by coming to us and then being able to go ahead and go to their communities and distribute them. I think that this is really useful in geographies or in communities where there's lack of access and they're particularly rural or frontier, and usually folks are limited in terms of having access to transportation. So there's maybe a person who's able to connect with the Syringe Exchange because they already have a relationship, and then they can come to us and they can get supplies for themselves and for members of the community that need them. Also, there's a built-in trust. Folks know, who to trust, and they trust folks that have similar experiences as them, so they can go and support folks that are going through the same situations that they are, and help us build trust as a program with those folks. And it's also honoring the expertise, the knowledge, the amazing brilliancy of people that use drugs, and they know what they need, and they know how to take care of themselves and how to best be healthy. And I think that when we support secondary peer delivered exchange or programming, it is also honoring the resiliency and the autonomy of people that use drugs, and we trust them that they know what they need to do to take care of each other, and to take care of our community. Is there anything else that you would both add in terms of maybe challenges? I can think of some, but I know you both have also, we've talked about this, so I know that you have some ideas around that.
Yeah, sure. One of the biggest challenges that presents with peer-delivered syringe exchange is around paraphernalia laws and whether a syringe is still considered paraphernalia under laws. If these peers or secondary exchangers are employees of your syringe service program, that is generally, I can't speak to all states, but generally a way around these paraphernalia laws. So what we've heard from programs in states that have these policies is that they make, regardless of whether they're paid or just volunteering or just participants who say, hey, I'm bringing these back to everyone that I know, they make all of their participants volunteers at their programs so that they can legally carry any number of syringes without fear of criminalization. Of course, that's not a perfect system, and people carrying a large amount of syringes who are already targets for police profiling, whether that's people of color, trans people, people who have criminal records, may still be stopped and searched and criminalized for carrying large numbers of syringes. So that is, to me, the largest challenge. I will also just add, as someone who supervised a large peer delivery program and also has done peer delivery in my own community, it can also be really, while burnout is real and something to be addressed for anyone working in syringe services, peer-delivered exchangers are especially vulnerable to burnout because there's often no clear line between when they're at work and when they're in their social communities.
Yeah, I don't think I would have much else to add because I've had similar experiences. Yeah.
I would also say that for sometimes what happens is that maybe folks move away, or folks, decide to transform their relationship to the way that they engage with substance use, and then they may not be coming to us. And that means that if that was the only person who was doing the peer delivery, that may present a challenge in terms of, making sure that the folks that were getting connected to the services continue to do so. So it's about, thinking about engaging in those conversations with folks that are doing peer delivery to really, be supportive of them as they're supporting other folks as well. And then finally, we're moving to pharmacy model. And that basically is pretty straightforward, right? Is having folks having access to syringes by purchasing them through the pharmacies, right? Some advantages is pharmacies can be open during hours that syringe exchange programs or syringe service programs are not open. You can go in and purchase them if you have money to do so. I think some of the challenges are stigma around, particularly in small communities where you have smaller pharmacies, and sometimes pharmacists may not want to sell syringes to folks because they don't want to sell syringes to people that use drugs, or going into the pharmacy and knowing the pharmacist because it's a small community again, and they will know your business. So it's less anonymous. You're more out there as a target for discrimination and stigma. What are other things that you can think of in terms of pharmacy access for folks?
I think from my experience as well, is that, it is, like you say, it expands access and the times that people can access materials, but they don't always get the same level of, like, say, for example, safe for use education that they would get from coming to a storefront or, a mobile-based outreach program. So That's one of the downsides. One of the ways, my program, we actually used all 4 of these models to some extent, including, engaging with local pharmacists and having pharmacy students come and volunteer with us. So that increased their cultural competency and humility, so that when they then went to work in a pharmacy, what you spoke about, Tanagra, people being stigmatized, they were far less likely to stigmatize people and far more understanding of people's needs when they came into a pharmacy to get supplies. So that was another way that we kind of addressed stigma and promoted pharmacy access.
Absolutely.
Yeah, thank you, Emma and Tanagra. The only thing I would add really is that pharmacy is the only option on here that would cost a participant any money. And they may in a lot of cases very likely are limited in what supplies they stock and provide. So folks are not likely to find cookers or fentanyl testing strips or things of that nature at a pharmacy, and the pharmacy may carry a different brand of syringe than what folks are used to getting at an exchange or from friends.
Absolutely. Thank you, Casey and Emma, for that.
I think I just wanted to reiterate as well what you said, Tanagra, about options for health departments and CBO partnerships, in that we've seen over time, as the approval and funding does trickle down and come through health departments often, but encouraging health departments to seek out the CBOs in their communities that may be already well connected to people who use drugs through existing, services that they're providing, and maybe better placed to actually provide the syringe service programming models, or like you said, a combination. So for example, in Louisville, the health department runs one site and then it works with a local CBO to run satellite sites. So I think that's a great way to partner, especially with CBOs, like I said, that already have those connections and relationships and that cultural safety that you spoke about for people who use drugs, and the supportive role of health departments that can play in supporting CBOs to provide services versus feeling like they have to be the ones to do everything themselves. Especially in areas where health departments also have, don't struggle with staffing capacity and resources too. So like sharing the capacity or delegating the capacity to provide those services. We see there's a really good model in Bloomington, Indiana, for example, where Indiana Recovery Alliance provide the services through approval from the health department versus the health department doing it themselves. Thank you, Emma.
Thank you.
So I was thinking about whether, regardless of what model or combination of syringe service programming model you use, definitely think about distribution models and what you're able to distribute in order to keep folks safest and provided with the highest number of sterile supplies. Emma's already mentioned that needs-based, which is total access to whatever syringes and other supplies folks need, is the best practice over exchange. It allows people to have enough or more than enough supplies to stay safe. But we also acknowledge that in a lot of syringe service programs, the funding isn't there to allow access to total needs-based access. So thinking through what you can give. For example, if it's at all avoidable in your state or locality, avoid doing a one-for-one exchange, because that doesn't give people the amount that they need in case something happens, in case they miss their shot or a syringe breaks or they lose their gear or have things stolen. So thinking through, if you have to accept some back in order to give syringes out, thinking through what you could do. Could you do a 1 for 10 model? Could you do a 1 for 20 model? The more you can give for every syringe returned, the better. It's just going to keep folks safer. Anything to add, Tanagra?
I was just going to say that I think that the piece that for me is really important around this is really having transparency and truthful and honest conversations and trusting our participants to tell us what's best for them, what works best for them and what they need, and to understand why is it that they're requesting. I've heard from some folks, it's like, oh, they're requesting this amount, and let's talk about why, because if they're doing peer delivery or they're doing secondary exchange for folks in their community, then it makes sense for them to carry that number of that amount of syringes. And if our programs sometimes I know are limited by funding, right? And we wish we could give more, but we don't have the capacity to do so because our funding doesn't permit us, then you negotiate with your participants, right? But I think it's important when we're thinking of stigma and stigmatizing folks to not make assumptions and to trust our participants and to trust that they are the experts in their process and that they know what best works for them and see and figure out ways in which we can provide that, right? That's why access versus exchange is so important. But if that's not a reality for us, to really be transparent and honest why that is not, and to try to get as close to that as possible. You know what I mean? I think that for me is really crucial when I'm thinking of this.
Yes, absolutely. Thank you for highlighting that, Tanagra. Speaking with participants and trusting that what they tell you is true is so important in deciding how and what you will distribute. All right. Emma has already addressed a lot of this, but we certainly want to reiterate that syringe service programs are not just about the syringes. That's why we've kind of switched from calling them syringe exchanges to syringe service programs or syringe access services, because there's a whole host of other services provided. People who visit syringe service programs have access to detox and drug treatment programs through supportive referrals. Those supportive referrals also will give them access to medical, dental, and mental health services. In many syringe service programs, there are medical and mental health services on site. For people engaged in the sex trade, it may mean access to a bad date sheet or a recording of abusive clients who other sex workers have identified in the area. Often Hep A and B vaccinations will be offered at syringe service programs. These are extremely important because if you have hepatitis C and hepatitis A or hepatitis B or all three, your liver is getting, an analogy one of our colleagues likes to use is your liver is getting punched by three different guys. HIV and hepatitis C services, whether that is rapid antibody testing, full RNA testing, treatment, or some combination of those. And for programs that aren't able to treat people on site or provide inflammatory testing on site, again, there will be supportive referrals made to access those services. Lots of syringe service programs offer linkages to housing services. Folks can receive safer injection demonstrations and information about how to inject safely at syringe service programs. Safer sex supplies and education are also available through syringe service programs. And almost every syringe service program in the country distributes naloxone and talks through the increased risks of fentanyl versus heroin. Lots of programs also offer prevention for non-injectors. So for people who smoke their drugs, they may offer pipes and screens and pipe covers. For people who snort their drugs, they may offer straws and something sterile to cut lines with. And again, syringe service programs just promote the leadership of people who have used drugs, shifting those resources and powers back to the communities impacted by substance use and the individuals impacted by substance use. Tanagra, anything to add? Oh.
No, I think that covers it. I think that the most important thing for me of what you mentioned is that, syringe service programs are the spaces where people feel safe to come in and build connections that where they feel that they can trust the folks to listen to them and to be able to connect them to other services and linkages within the community, or just to find a safe space to be. And I think that when I worked at the drop-in center that I worked in Massachusetts, that's one thing that we saw was that sometimes we had participants that had gone on to, follow sobriety, and they still came and had coffee and sat down and were part of the groups and and supported us in doing outreach, because they felt part of that was their community, and they felt safe in that space, and they felt welcome and loved. And I think that's, for me, the beauty of just Syringe service programs is that it really highlights the humanity of people, you know?
Yeah, absolutely. I'm really glad that you used that example, because that's also an experience I had, or the experience I had working at a Syringe service program in New York City. Lots of our folks were either engaged in medication-assisted treatment or completely or absent from the street drugs and medication-assisted treatment, and they still came through because this was their community. So yes, thank you, Tanagra. I think that drop-in centers are a really important benefit of Syringe service programs as well, and the community and trust that they uniquely, those spaces to hang out and be yourself can build. Very important. All right. So syringe access can and does reduce HIV incidence. It is one of the most effective evidence-based HIV prevention tools for people who inject drugs. Other effective evidence-based prevention tools include medication-assisted treatment, because if you are on a medication, you are not necessarily injecting drugs and at lower risk for contracting HIV. Multiple federal agencies, including the CDC, SAMHSA, HRSA, and NIDA, include the use of sterile syringes to prevent the spread of HIV and other bloodborne infectious diseases in their education and research materials. So this is supported by the federal government. There's lots of research backing their evidence. And people who inject drugs, I want to be really clear that though harm reduction is now an intervention supported by these federal agencies, supported by many local health departments, harm reduction and the distribution of sterile supplies to people who use and inject drugs was pioneered by folks who inject drugs and their loved ones, and people engaged in sex work and their loved ones at the start of the HIV epidemic in this country, at least. And so harm reduction, like people who inject drugs who began in spite of legality, distributing sterile syringes to their loved ones and to their communities, have reversed the course of the AIDS epidemic by using these sterile syringes and these harm reduction practices well before it was legal. And we're seeing this again with the overdose or opioid crisis. People who inject drugs, people who use drugs, and their loved ones have to give a special shout out to Dan Bigg. We're the first people to distribute naloxone on the streets to people who use drugs, to people who inject drugs, regardless of legality. And again, folks who use drugs and their loved ones are the true first responders in the midst of the overdose crisis. All right, and finally, talking about reduction in Hep C transmission risk. So, according to a study done on people who inject drugs from 2005 to 2006, so again, a little older, but still important numbers, almost a third of people who inject drugs report that they have shared syringes or other equipment across the country. Many participants of syringe service programs are referred to the Hep B vaccination series and the Hep A vaccination series, because lots of folks who were not born prior to 1992 haven't received these vaccinations, and folks who are test reactive for hepatitis C at syringe service programs are linked to confirmatory testing and linked to treatment. There is a cure for hepatitis C, so being able to access that care through the initial point of contact of syringe service programs is very important. And then safer injection equipment and education around injection assist people who inject drugs who don't have Hep C to stay that way. People learn how Hep C is transmitted and are able to avoid practices that have transmitted Hep C. All right. finally, I want to highlight how to talk to people about drug use. We've said it again and again throughout this presentation, but really think about who the real experts are. The first day that I started volunteering at a Syringe service program, my supervisor said, you want to learn about our services? You want to learn about what we offer? Talk to the real experts. And what he meant was talk to the participants at the program. So really thinking through and framing in your mind for yourself the fact that people who use drugs and the people you serve are the real experts on the services that you're trying to provide. Think through how you ask and listen. We're humans. We all make internal judgments all day, every day. But checking those judgments, using a neutral tone, asking questions with caring curiosity, asking open-ended questions so that people don't feel like they have to offer a yes or no and the conversation ends there. And then also stepping back and listening more than we speak as service providers is super important. And recognizing that sometimes people aren't ready to talk, and that's okay. Letting a conversation be over when it's over rather than pressing for more information. Thinking through how you offer information, again, being practical and realistic, laying out all of the options available, laying out everything that, laying out all of the information related to the thing you're talking about, and allowing people to make their own decisions, not steering people in the direction of one decision versus the other. And also stepping back if someone says, hey, I don't want that information right now, and saying, okay, great, I hear you, and I am here if you change your mind. And then thinking through how we answer questions, thinking through whether we're self-disclosing things that would help or harm folks, thinking through whether we're answering questions from a place of wanting to support folks or wanting to prove ourselves, really thinking about how we're engaging with people in the ways that best possibly support them. Tanagra, do you have anything to add?
I would say, thank you, Casey. No, I think that when I was listening to you speak to these, that for me, what helps me is to really frame the way that I engage with folks through the lens of the principles of harm reduction, right? And it's about dignity and respect. It's about being participant-centered, honoring participant autonomy. It's really about understanding the intersections of people's identities and giving people choices and respecting humans and their choices that they make, right? I always think that I want to treat people the way that I want to be treated, and I want to be treated with dignity, with respect, with love and caring and empathy. And if we can make that exercise, even if we don't understand or it's not our experience, it can help us build much more trusting and honest relationships with people that are grounded in transparency, right? So, I think if you open the door for people to trust you, they will share with you and they will feel comfortable telling you, I am not ready for that information, or I don't need it because I already know that. Thank you. And to be prepared to be humbled, which I think it's also an important piece when we're thinking of providing services and engaging with folks in any capacity, right?
Mm-hmm. And I think one thing I'd add, especially what it makes me think when I see the last point about how we answer questions, is being ready to say I don't know, and being honest and not pretending to have all the information, and but being honest and then being consistent and going away and say, you know what, I'm going to go, let's go find out. Or I've sat with participants and Googled stuff because we have access to the internet these days. So, but being honest when you don't know the answer, but taking the time to go and find that out if that person does want you to go and do that.
Totally. And I think that speaks to Tanagra's point. Tanagra, we were over here enthusiastically nodding at each other when you said, be ready to be humble. And I think part of being ready to be humble is being ready to say, I don't know. Your point.
Yeah. All right. Well, we're beginning to wrap up our presentation. I just wanted to give a very brief outline of our Replace community mobilization model, which is something that would be the next step of working with programs as they move towards actually establishing and developing themselves. And so this is an acronym where it stands for awareness, policy, leadership, alliances, cultural competency or cultural And these are different stepping stones or buckets that we work through with people to think about all the different aspects that they might need to consider as they move towards setting up a syringe service program. So I'm just going to touch on that here and not go into too much detail, but just wanted to mention that's another option of capacity building support that we have. And I want to end our presentation with a wonderful quote from our colleague Rafi, who runs a program in Puerto Rico, and I think this echoes a lot of what we've heard through today's presentation about harm reduction is revolutionary love, and it's very real and it's very concrete. And what Rafi talks about is that they embody, that we embody as much as possible this by creating a loving space that's really caring for people. And then just finally to say thank you. And I'd also like to acknowledge our colleagues AMFAR, including Greg Millett, who allowed us access to some of the data that you saw on the slides today. So we wanted to acknowledge them as well. So thank you, everyone. Thank you, Casey.
Thank you, Nagra. Thank you, Emma.
Thank you, everyone. Thank you so much.
Thank you. Thank you for joining us today.